Mel, Portugal. Yes, if you can. She will speak about isolation and detection of circulation tumor cells on a chip.
Okay. Hello. So my name is Lorena. I come from the International Ovarian Nanotechnology Laboratory in Portugal, and I'm talking today about label-free isolation and multiplex analysis of circulating tumor cells on chip. The goal for us is to develop non-invasive monitoring of cancer metastasis. We have just heard, Isabel, of how important it is to catch metastasis early. And actually being able to catch metastasis early would actually give us, let's say, open a window to early detection, accurate prognosis, and personalized treatment of cancer. And what we want to do is to develop an in vitro diagnostic system for personalized management of cancer, and we will see if we are able to do that at the point of care. The idea is that we would have a non-invasive sample from the patient, we would have a system that would be able to analyze it in less than 1 hour, and we would be able to give a report to the oncologist straight away so that they can design the perfect treatment for that particular patient. So what is the situation with cancer? Nowadays, 1 in every 3 people will suffer from cancer at some point in their lives. But in an aging population, this means that in the next 10 years, it will actually be 1 in every 2nd person that will have cancer. However, nowadays, cancer is very well managed, and most of the people that are diagnosed are cured, which is really good. But 60% of these people will actually relapse, having cancer spread and having metastasis diagnosed. And it's metastasis that is responsible of most cancer-related deaths. So to be able to catch metastasis early, there's an obvious need for continuous cancer progression monitoring. But the tools are used in the clinic, which are tissue biopsy at the diagnosis point, and then imaging technologies as the disease goes by, are not able to catch, let's say, metastasis at the earliest stage. So they miss early spreading of the disease. But there's a way in which cancer can be monitored in a minimally invasive way through a blood sample. And this is what is called liquid biopsy. There's 3 major biomarkers that are known to be studied in liquid biopsy: circulating tumor cells, circulating tumor DNA, and exosomes. We are focusing on CTCs. There's one system, which is the cell search, that is the only system approved and validated for clinical use of CTCs. And what they do is they isolate tumor cells that have an epithelial phenotype using magnetic beads that are labeled with EpCAM antibody. But the problem is that cancer is a very heterogeneous disease, and not all cancer cells are actually epithelial. Actually, it is very well reported that when circulating tumor cells enter circulation, and when they leave circulation to invade a secondary organ and create a secondary tumor, they actually mutate and they lose this epithelial phenotype. Hence, capturing and studying epithelial cells might not be relevant. So what we want to do, our goal was to develop a phenotype-independent system to isolate circulating tumor cells. And we thought of doing that based on size. But in the blood, you get white blood cells, red blood cells, and possibly circulating tumor cells that are very, very rare. The ratio is 1 CTC for several billions of blood cells. And the size of white blood cells and CTCs can actually overlap, as you can see. So what we did was to develop a size-based isolation based on microfluidics that actually takes into account the formability of cells. So if you look closely, what we've got is an array of posts that have a particular aspect ratio so that the white blood cells are able to deform and squeeze through these gaps and flow through the system, while the CTCs are not able to deform and hence get trapped. These are 2 small videos of how the system works. And I just want to highlight here that we wanted to design a system that was able to process whole blood. Because if you do any kind of sample processing, since the number of these cells is so small, these cells are so scarce, you're losing your targets already by doing any kind of sample processing. So by doing a surface chemistry using hyaluronic acid on the surface of the channels, we were able to allow for all the cells to flow through without any let's say, non-specific binding to the surface. And what we did just to validate this part, we ran a preclinical study comparing the performance of cell search against our system. And we took a pool of metastatic colorectal cancer patients from EDIS in Santiago de Compostela. And we compared the performance of cell search against our technology. You can see that the number of CTCs that we were able to isolate can be up to 40 times higher. And what we do then is to characterize the phenotype of these cells by fluorescence microscopy. Now, this is all great, and we were able, we have a paper under review and another one already published in bladder cancer. But the problem is that the oncologists actually want to assess many biomarkers in each of these cells. And by fluorescence microscopy, we are not able to do that. And this is where the second part comes. We were looking for a technique that has the ability to multiplex several biomarkers at the same time, that is quantitative, very sensitive, that offers us high throughput at the single cell level, and that involves minimal handling of our sample, not to lose the very few CTCs that we have on our patients. And we came up with the idea that combining microfluidics with surface-enhanced Raman spectroscopy would be the best way to do so. So very briefly, otherwise Alex would kill me, surface-enhanced Raman scattering consists on using molecules that we call Raman reporters, which have a very well-defined Raman spectra, coupled to plasmonic nanoparticles that enhance their signal very much. Now, if you do use several plasmonic nanoparticles together or anisotropic nanoparticles, you create hotspots that actually enhance the signal even further. In a nutshell, what we do, we synthesized gold nanostars that we then label with Raman reporters, encapsulate them in a silica coating, and then conjugate them against antibodies that recognize specifically proteins that we are interested in at the cell membrane level. This is what we call our codes. And we have so far developed 6 different codes pairing Raman reporters with antibodies. Then we do the cell labeling. But we actually do all this in microfluidics. So one of the major well-known techniques in microfluidics is the ability to study microdroplets. So what we do is we inject the cells on the chip and the codes on the chip at the same time, so that we are able to encapsulate one single cell in each microdroplet that is already labeled with the Raman reporters. And then we just perform the detection in line in real time without any kind of sampling handling. And in milliseconds, you would be able to get a signal from each of these cells for the different biomarkers in a quantitative way. Well, just for the ongoing work, we have several preclinical trials ongoing with different hospitals, mostly in Portugal, in breast, colorectal, bladder, melanoma, and I don't know what I missed. We are doing this not only in blood, but also in other body fluids, particularly in urine, in the context of early detection of bladder cancer, and has been quite successful so far. We have also been engaged in innovation on the tech transfer side of things, because we do believe that this could be in the clinic. And those are, we started with the NanoMed last year, but we have gone through several accelerators and innovation contests and programs. And we are working now towards not only profiling the proteins in the membrane of the circulating tumor cells, but being able to do intracellular profiling, as well as simultaneous analysis of circulating tumor DNA on the same sample. Then we are also working towards organ-on-a-chip 3D microfluidic models of disease, particularly of metastases, so that we can study how these CTCs behave on an in vitro model. And then drug testing platforms, actually testing drugs on the CTCs derived from each patient to know what therapy would be best for each of the patients. And that's all. I don't know if I took too much time, but thank you for your attention.